Chapter 16, diseases of the liver, gallbladder, and the exocrine pancreas. Learning objectives: discuss the anatomy and physiology of the habitability system, the gallbladder, and the pancreas. Discuss the laboratory methods used in the management of hepatic disease. Identify the symptoms and causes of jaundice, portal hypertension, and hepatic encephalopathy. Identify the types of hepatitis and the causes of non-alcoholic fatty liver disease, alcoholic liver disease, and cirrhosis. Understand the appropriate nutrition assessment, diagnosis, and intervention for hepatitis, non-alcoholic fatty liver disease, alcoholic liver disease, and cirrhosis. Differentiate between acute and chronic pancreatitis and their causes. Understand the proposed etiologies, typical medical care, nutrition implications, medical nutrition therapies, and specialized nutrition support for acute and chronic pancreatitis. The liver, pancreas, and gallbladder are accessory organs of the gastrointestinal tract. Though referred to as accessories, all three organs are essential components required for digestion, absorption, and metabolism of nutrients from food. The liver is one of the largest organ in the body, weighing about 3 pounds in an adult. It influences nutritional status through the synthesis of bile salts and metabolism of protein, carbohydrates, fats, and vitamins. The liver is located in the upper quadrant of the abdomen, following the curve of the diaphragm. The healthy human liver is brownish red in color. When highly infiltrated with fat, it becomes a dark yellowish brown mustard color, and through some disease processes can become fiber optic, where functional cells are replaced with scar tissue. There are 4 anatomical lobes of the liver: the right lobe, the largest, quadrate lobe, caudate lobe, and the left lobe. The right lobe receives blood from the right hepatic artery, and left lobe receives blood from the left hepatic and middle hepatic arteries. The basic function unit of the liver is its lobules. Each lobe is made up of thousands of lobules. The liver lobule is constructed around a central vein and empties into the hepatic vein and then into the vena cava. The lobule is composed of many hepatic cellular plates. Each plate is about 2 cells thick. Between the adjacent cells are bile canaliculi, which collects bile produced in the cells and carried into the hepatic terminal bile duct. Understanding the vascular supply, both serum and lymphatic, is essential. The main blood and lymph vessels, bile ducts, and nerves enter and leave the liver through an opening called the hilum. Figure 16.1 is the gross anatomy of the habitability system. It talks the biliary system, which includes your gallbladder, which stores and secretes bile, and the bile ducts, which conduct bile from the liver to the gallbladder and from the gallbladder to the intestines. Hepatic vein returns blood from the liver to the heart. Hepatic artery supplies oxygen-rich blood from the heart to the liver. Your portal vein carries nutrient-rich blood from the digestive tract to the liver. Your GI tract veins transport absorbed nutrients to the portal vein. The liver receives nutrients from the digestive tract and processes them for distribution throughout the body. Figure 16.2 is just the anatomy of the lobules. So please review the different areas of the lobules. Figure 16.3 is the circulation of blood to and from the liver. The liver receives blood from two sources. You have arterial blood, which provides the liver O2 supply and carries blood-borne metabolites from hepatic processing and is delivered by the hepatic artery. Then you have venous blood draining from the digestive tract and is carried by the hepatic portal vein to the liver for processing and storage of newly absorbed nutrients. And blood leaves the liver via the hepatic vein. The liver has over 500 known functions which are essential for nutrition metabolism. The liver is a site for glycogen storage that facilitates a ready source of glucose when it is needed throughout the body. The liver is the site for both transamination and deamination of amino acids. It is also the site for synthesis of proteins such as albumin, prealbumin, retinol binding protein, and clotting factors needed for blood coagulation. Lipid metabolism is coordinated within the liver as it receives triglycerides from circulation and allows for redistribution throughout the body using lipoproteins produced in the liver. Bile is a complex aqueous solution secreted by the liver and serves as a emulsifying agent that decreases surface tension and allows for intestinal agitation to break up the globules. Bile salt facilitates the absorption of fatty acids, monotriglycerides, cholesterol, and other lipids by forming minerals that are soluble in chyme. Without bile salt, a large percentage of ingested fats would be lost in the feces. Bile is composed of cholesterol, bile pigment, bile acids, phospholipids, and bicarbonate. Intrahepatic circulation of bile. About 95% of the bile salts are reabsorbed into the blood from the small intestine. About half by diffusion through the mucosa in the upper small intestine and half by active transport through the intestine mucosa in the distal ileum. Figure 16.4 is intrahepatic circulation. So it's secreted bile salts consist of 95% of old recycled bile salts and 5% of newly synthesized bile salts. 95% of bile salts are reabsorbed by the small intestine, reabsorbed by bile salts, or recycled by the intrahepatic circulation. Table 16.1 is a summary of the liver functions. It goes over carbohydrate metabolism, lipid metabolism, protein metabolism, and enzyme metabolism. This is just this chart continued going over vitamin metabolism, bile acid metabolism, heme metabolism, storage, and other functions. Please review the liver functions. The gallbladder is on the underside of the liver and the right side of the abdomen. The biliary tract is the anatomical path that the bile takes after it is secreted by the liver and concentrated in the gallbladder and before it arrives in the duodenum. Bile is secreted into the intestine in response to the presence of food. The functions of the gallbladder are as follows: removal of water and electrolytes from bile, which increases concentration, storage of bile, control of delivery of bile salts to the duodenum. The pancreas is a large accessory digestive gland located behind the stomach and opposite of the duodenum and the spleen. The pancreas is divided into segments. You have the head, which is the wider portion of the pancreas, followed by the neck, the body, and the tail. The pancreas is the only organ in the body that has endocrine and exocrine functions. The endocrine functions, the primary role is the secretion of glucoregulatory hormones, and the exocrine function is responsible for secreting digestive juices into the duodenum. Figure 16.5, this is the anatomy of the pancreas. Table 16.2 is the pancreatic exocrine secretion. So it goes over the enzymes, the substrates, and actions and product of actions. Please review. This chart is continue with the enzyme, substrate, action, and product of action. The use of imaging, biopsy, and lab tests are the foundation for diagnostic procedures of the biliary system. Imaging of the liver, pancreas, and gallbladder can be accomplished by using an ultrasound, CT, and MRI. These are the primary tools for the evaluation of the structure and function of the liver, pancreas, and gallbladder. Lab tests are useful in the evaluation and management of patients with organ dysfunction, but it is estimated that up to 75% of liver function can be lost before clinically evident. The most common tests used are bilirubin, aminotransferase, alkaline phosphate test, and prothrombin time. The secretion stimulation test provides for a measure of the ability of the pancreas to release pancreatic secretion in response to secretin. Jaundice is a yellowish tint in the body tissue caused by large quantities of bilirubin in the extracellular fluid. The skin and eyes appear jaundiced when serum bilirubin exceeds 2.5 to 5 milligrams per deciliter. Some of the symptoms include hematologic jaundice, obstructive jaundice, newborn jaundice. Newborn jaundice is very common. It's the immature liver is unable to metabolize bilirubin quickly enough. Portal hypertension is elevated blood pressure in the hepatic portal vein. The majority of causes are related to cellular change intrahepatically, where cirrhosis is primary cause. The primary symptoms and complications of portal hypertension includes ascites, which is the accumulation of fluid within the peritoneal cavity. Figure 16.7 is an example of ascites. Figure 16.16 talks about the portal hypertension, transjugular intrahepatic portal systemic shunt, and the distal splenorenal shunt. Hepatic encephalopathy is a syndrome of impaired mental status and abnormal neuromuscular function that results from the consequences of liver failure. Table 16.4, this is the West Haven staging scales for hepatic encephalopathy. So it starts, this chart right here goes from stage 0 to 2. The next one goes over stages 3 and 4. The pathogenesis of hepatic encephalopathy is multifactorial and involves the inability of the liver to metabolize products that are toxin to the brain. Potential contributions could be increase of serum ammonia, neurotoxins produced by intestinal bacteria, and production of false neurotransmitters. Figure 16.8 is the normal utilization of ammonia and formation of urea. Please review. Treatment focused on reducing circulating ammonia, so 1.2 to 1.5 grams of protein per kilogram of dry weight is recommended, assist in preventing catabolism and the increase of ammonia production. Hepatitis is an inflammation of the liver caused by virus, bacteria, toxin, obstruction, parasites, or chemicals. Viral hepatitis is caused by 5 identified viruses. So you have type A, B, C, D, and E with at least 20 other viruses under study. Acute hepatitis A, transmitted almost exclusively by oral fecal routine. Sources include contaminated drinking water, food, and sewerage. Serum hepatitis or hepatitis B is transmitted via blood-derived fluids, improperly sterilized medical equipment, or other skin puncturing equipment or instruments. Can be acute or chronic. Complications include cirrhosis or hepatic cellular malignancy. Hepatitis C, exposure to blood or bloody fluids from an infected person associated with development of chronic liver disease, cirrhosis, and need for liver transplant. Hepatitis D and E, unknown, requires hepatitis B to reciprocate. Acute infection and is very rare in the United States. Nutrition therapy for viral hepatitis. So nutrition implications: nausea and anorexia with weight loss and nutritional deficiencies. Nutrition assessment: weight and weight history, food intake, and lifestyle factors. Nutrition diagnosis would include inadequate oral food or beverage intake, inadequate protein and calorie intake, food, medication interaction, and impaired nutrient utilization. Nutrition intervention: provide nutrients needed for liver regeneration, avoid alcohol, monitoring and evaluation. Evaluation focuses on measurement of desired outcome. Alcoholism, alcohol abuse represents one of the most significant health problems in the United States. It is a costly disease with serious physical, psychosocial, and nutritional implications. Much of the morbidity and mortality associated with alcohol abuse is attributed to its toxin effect on all major organs, with alcoholic liver disease being the primary cause of chronic medical illness and death. The pathophysiology of alcoholic liver disease comprises a spectrum of 3 disorders: fatty liver, alcohol hepatitis, and cirrhosis. The consequences of excessive alcohol ingestion include acetaldehyde toxicity, metabolic competition, induced metabolic tolerance, cerebral degeneration, and malnutrition. Alcoholic hepatitis is a toxic liver injury associated with chronic ethanol consumption, presents with nonspecific symptoms of nausea and a low-grade fever. Clinical presentation may include fatigue, weakness, anorexia, and/or fever. Malnutrition is a significant risk for individuals with alcoholic liver disease. Recognition and expedient treatment of malnutrition is a key component of successful nutrition therapy. There are multiple screening tools such as the Subjective Global Assessment, Malnutrition Universal Screening Tool. Though these tools are valid instruments, many may not be sensitive enough to identify sarcopenia. Using the nutrition-focused physical exam may allow for a more comprehensive approach to assess for malnutrition. Still, fluid accumulation of sarcopenia complicates the accuracy of the nutrition-focused physical exam. Common diagnoses: increased energy expenditure, inadequate energy intake, inadequate oral food, beverage intake, malnutrition, impaired nutrient utilization, underweight. Nutrition interventions: initial abstinence from alcohol and treatment of withdrawal symptoms, correction of nutritional deficiencies, as well as prevention of treatment of malnutrition. cellular monitoring and evaluation, measurement of tolerance to feedings, amount of nutrients consumed, dry weight changes, any lab values, and evaluation of the patient's functional status. Fatty liver or cirrhosis occurs in 25 to 30% of general US population, up to 35% of worldwide population, and 90% of chronic alcohol abusers. The broad term non-alcoholic fatty liver disease refers to a wide spectrum of liver diseases ranging from cirrhosis, fibrosis, and cirrhosis. There is an added risk of hepatic cellular carcinoma when the disease progresses to the stage of cirrhosis. Many patients with non-alcoholic fatty liver disease are virtually asymptomatic, and diagnosis may only occur as a result of testing or screening for an unrelated condition. Diagnosis is typically made using information from both history and physical exam. Conditions associated with the fatty liver can be alcoholism, type 2 diabetes, metabolic syndrome, PCOS, obesity, sleep apnea, dyslipidemia, parental nutrition. These are some continued conditions. Nutrition is considered both as a factor contributing to the etiology for non-alcoholic fatty liver disease and a component of treatment. Fructose is a major subject of research for the potential impact on the etiology of non-alcoholic fatty liver disease. Fructose is readily available in fruits and other food sources, but high fructose corn syrup has been increasingly used as an added sweetener. This increased intake of fructose has been proposed to be a contributing factor to the non-alcoholic fatty liver disease. Excessive energy from carbohydrates and lipids will be converted to triglycerides. When input of triglycerides is greater than physiological requirements, triglycerides can accumulate within the hepatocytes. Decades of research have supported the underlying and understanding of increased dietary fat with the onset of obesity, atherosclerosis, and other chronic diseases. Gut microbiome changes in the gut microbiome are linked to multiple chronic diseases such as type 2 diabetes, obesity, and other inflammatory conditions. So nutrition therapy, you need to find the etiology of the non-alcoholic fatty liver disease and understand that it's multifactorial. We've just gone over the different causes. Some nutrition research and treatment has focused primarily on weight loss, addition of specific nutrients through supplementation, use of the Mediterranean dietary approach, principles for creating a dietary pattern. Table 16.6 goes over the oral nutritional supplementations offered, often given to chronic alcoholics. A major one would be thiamine. Please remember, thiamine is one of the supplements that is given often to people that are chronic alcoholics. This table is continued on the next slide. Cirrhosis represents the end of the pathophysiological spectrum for a wide variety of chronic liver disease in which damaged hepatocytes are replaced by fiber optic scar tissue, blocking the flow of blood through the organ, resulting in the loss of liver function. Even when irreversible liver complications are present, therapeutic interventions, primarily nutrition treatment, can alleviate major complications of cirrhosis, such as encephalopathy and manifestation of portal hypertension, such as ascites. Most common cause of cirrhosis in the United States is hepatitis C, alcohol liver disease, hepatitis C plus alcoholic liver disease. Cryptogenic causes may be due to non-alcoholic fatty liver disease, hepatitis B, and some miscellaneous reasons. Miscellaneous causes of chronic liver disease and cirrhosis are listed below. Immune hepatitis, Wilson's disease, type 4 glycogen storage disease, drug-induced liver disease. Please review. General symptoms of cirrhosis would be fatigue, weakness, nausea, poor appetite. Another general symptom could be malaise. Liver-specific symptoms could be jaundice, dark urine, light stool, steatorrhea, itching, abdominal pain, and bloating. Vitamin mineral deficiencies are very common, especially thiamine. Portal clinical complications could be major clinical complications could be things such as portal hypertension, hepatic encephalopathy, ascites. Treatment, abstaining from alcohol, treatment of the complications that the patient is experiencing, and nutrition therapy. Cirrhosis as the end stage of a liver disease poses increasingly crucial nutritional concerns. The presence of malnutrition is very common in cirrhosis. Maximizing oral intake, correcting any micro or macronutrient deficiencies, and controlling physiological side effects of ascites and sodium and fluid restrictions make up the primary components of nutrition therapy for cirrhosis. The goal of nutrition therapy is to provide adequate nutrition to maintain or replace nutrition stores without triggering or interfering with treatment of clinical complications. Nutrition assessment, it should include attention to the physical assessment and steps to identify sarcopenia. The 2016 Aspen Critical Care Guidelines should be used for guidance in establishing energy and protein requirements, as well as timing of nutrition support if needed. Nutrition diagnosis may be related to particular complications of the disorder. Energy, nutrients, so protein should not be restricted. Carbohydrate restriction in patients with diabetes. Vitamin, minerals, sodium restriction in ascites, and other consideration, enteral feeding in patients that have inadequate oral intake, and soft diet for patients with have esophageal variances. So monitoring and evaluation. So tolerance to the feedings, you want to make sure the patient is tolerating whatever feeding they're taking, even if it's oral or enteral. Amount of nutrients consumed, the dry weight changes, any lab value changes, and functional status. Figure 16.9 is a sample meal made with low sodium ingredients. Patients on sodium restrictions can learn to prepare flavorful meals using minimally processed ingredients. For example, the filling for these stuffed bell peppers contain quinoa, vegetable seasoned with garlic, cumin, turmeric, ginger, cinnamon, and pepper. Transplantation is considered in cases where effective liver disease have greater potential to cause mortality than the short and long-term complications of liver transplant. The most common medical condition requiring a transplant in adults are chronic active hepatitis, cirrhosis, and biliary-related disorders. A patient's eligibility to be placed on the waiting list for a liver transplant is determined based on the MELD scoring system. After transplant, all patients require immunosuppressant drugs to prevent rejection of the new liver. So the nutrition therapy, nutrition implications, malnutrition and ascites, need for early nutrition support after surgery, foodborne infections. The nutrition assessment, we want to monitor the SGA, anthropometrics, dietary intake, and GI symptoms. You want to monitor biochemical lab values, assess for side effects or post-transplant medications. Nutrition diagnosis range from all of these on the slide. I'll just read a few. Includes increased energy expenditure, inadequate energy, oral, food or beverage or protein intake, altered GI function, altered nutrition-related laboratory values, food medication interaction, unintentional weight loss. Intervention, oral or enteral feeding is preferred. daily calorie and protein recommendations were 35 to 40 calories per kilogram and 1.2 to 1.5 gram of per kilogram. Other nutrients or individualized based on immunosuppressant drug regimen. Liver transplant monitoring and evaluation. Post-transplant patients should be monitored very closely and regularly for recovery and healing, dietary intake, tolerance to the diet, weight changes, incidence of foodborne illnesses, nutrient-related complications associated with medications. Cholelithiasis or gallstones is the formation of stones within the gallbladder or biliary duct system and one of the most common is one of the most common medical problems leading to surgery. There are basically three types of stones. You have a cholesterol stone, pigment stone, and a mixed stone. Cholesterol is a major component of the bile and is normally kept in a solution by bile acid, lectin, and phospholipids. However, when bile is supersaturated with cholesterol, it can crystallize and gallstones are formed. Biliary sludge is a mixture of microscopic particulate, usually cholesterol crystals and calcium salts, and is associated with many of the same risk factors of gallstones. Usually, the presence of sludge have fewer symptoms and may appear and disappear over time. Nearly 2/3 of patients with gallstones are asymptomatic. The exact cause of this disorder is very unknown. However, the presence of obesity, diabetes, inflammatory bowel disease, cystic fibrosis increase the risk of developing gallstones, as do rapid weight loss, fat-restricted diets, bariatric surgery, and cholesterol-lowering medications. Prolonged parenteral nutrition and short bowel syndromes can also cause biliary stasis and therefore increase risk of stones. The most common treatment for systematic cholestasis is laparoscopic surgical removal of the gallstones, of the gallbladder, excuse me. So laparoscopic surgical removal of the gallbladder. Surgical interventions is recommended for patients that are repeatedly symptomatic or having underlying conditions that make them more susceptible to stones or to the complications of gallstones. So the most common treatment for systematic gallstones is a laparoscopic surgery removal of the gallbladder. Figure 16.10 is the formation of the gallstones. Cause of gallstones: number 1, too much absorption of water from the bile. 2, too much absorption of bile acid from bile. 3, too much cholesterol in the bile. And 4, inflammation of the epithelium. When a gallstone passes from the gallbladder through the cystic duct and lodges in the common bile duct or in the head of the pancreas, this condition is called cholelithiasis. There is bile and the bile is no longer carried to the duodenum, and excretion of the bile pigments into the urine gives the urine a dark color. The feces no longer colored by bile pigments and hence can be a little grayish. Inflammation of the gallbladder. Cholecystitis generally develops secondary to obstruction, infection, and ischemia of the gallbladder. This condition can be acute or chronic. Nutrition implications: indigestion, decreased ability to digest fat, and increased abdominal gas. Nutrition assessment: you want to check weight and weight history. Diet should be used to determine intake and tolerance of specific foods. Medication for treatment of gallstones should be noted. cholecystitis, nutrition diagnosis, inadequate oral or beverage intake, excessive oral intake, altered GI function, food and medicine interaction. Before surgery, you want a low-fat nutrition prescription with modest protein content, small, frequent meals. Gallbladder should be inactive during acute attacks, achieved through NPO, nothing by mouth. After surgery, diarrhea is managed through increased fiber intake, monitoring and evaluation. Adherence and tolerance of the diet should be determined. Acute pancreatitis. Acute pancreatitis impacts anywhere from 4.9 individuals in the United States, with approximately 200,000 cases each year. There are 275,000 hospitalizations associated with acute pancreatitis. Acute pancreatitis is associated with multiple conditions. Trends in acute pancreatitis from 2009 to 2012 indicated that factors associated with acute pancreatitis included gallbladder disease, chronic pancreatitis, pancreatic cancer, alcohol ingestion, cigarette smoking, hyperlipidemia, and obesity. 40% of the cases are due to the gallstone passing into the bile duct and temporary lodging at the sphincter OD. Alcohol use accounts for 35% of the cases. The pancreas exocrine function is to produce numerous zymogens that are activated after they're released into the duodenum. Excuse me. Symptoms with acute pancreatitis, it can be asymptomatic or upper abdominal pain radiating to the back, worsening with ingestion of food. Medical diagnosis based on clinical symptoms and elevated lipase and serum amylase. Treatment, mild acute pancreatitis can be treated with intravenous fluids, and severe acute pancreatitis requires intensive care. Nutrition implications, high nutritional risk, nutrition assessment, urgent need for nutrition intervention is identified using tools such as the NUTRI score or the NR 2002. Interventions could be recommendations or dictated by the severity of the disease course. For mild acute pancreatitis, oral feedings and low-fat food choices are typically tolerated. For severe acute pancreatitis, early enteral nutrition is recommended. Monitoring and interventions. Patient's medical course and adequacy of nutrition support should be frequently monitored. The primary outcome goal is an overall improvement in symptoms with the progression towards resuming oral feedings. Chronic pancreatitis is a chronic, irreversible inflammatory condition that leads to fibrosis and tissue calcification. Chronic pancreatitis affects approximately 50 individuals per 100,000 throughout the world. Acute pancreatitis is more likely to occur in men than women, as well as in African American population, and typically presents between 40 and 50 years of age. Some of the factors associated with chronic pancreatitis includes alcoholism, cigarette smoking, and previous diagnosis of acute pancreatitis. Distinct causes of the disease is unknown. Genetics are thought to play a major role. So the pathophysiology, uncontrolled inflammatory cascade that produces a low level of local and systemic inflammation, sporadic epigastric pain, reduced ability to produce and or release pancreatic secretion and enzymes cause exocrine pancreatic insufficiency or EPI, chronic obstructive pancreatitis due to injury of the pancreatic duct, development of strictures or ductal obstructions, and additional classification of chronic pancreatitis, autoimmune pancreatitis. So the nutrition implications, nutritional status will depend on the underlying etiology of the disease and the level of endocrine and exocrine dysfunction. Acute pancreatitis can lead to malabsorption of macronutrients, fat, protein, and carbohydrates, and micronutrients. Nutrition assessment, NFPE, allows for in-depth assessment to determine malnutrition risk and physical signs of micronutrient deficiencies. Monitor labs, including the serum glucose, triglycerides, bun, creatinine, and white blood cells. Medication should be assessed for drug-nutrient interaction. Nutrition therapy diagnosis. Nutrition diagnosis could be range from altered GI tract, inadequate oral intake, inadequate vitamin intake, impaired nutrient utilization, excessive fat intake. Nutrition intervention, a higher caloric intake of 35 calories per kilogram per day is recommended. Protein needs 1.2 to 1.5 grams per kilogram per day. Pancreatic enzymes should be taken at each meal and or snack or prescribed to improve digestion and absorption. Supplementation of vitamins and minerals as typically recommended. Food choices associated with the Mediterranean dietary pattern may be have a protective effect against pancreatic cancer and other diseases. Monitoring and evaluation, tolerance to the diet, use and understanding of the PERT, weight, degree of pain, signs of steatorrhea, evidence of macronutrient deficiency, including regular bone density. Pancreatic surgery. Surgical resection of the pancreas may be required in the case of malignancy, necrosis secondary to acute pancreatitis, assisting with the control of symptoms associated with chronic pancreatitis. It leads to change in motility, digestion, and absorption. Patients with a high risk of dumping syndrome are placed on the anti-dumping diet. Nutrition therapy recommendations focus on a high-calorie, high-protein diet divided into multiple small meals. Caloric intake should not be restricted. Vitamins and mineral status should be assessed periodically so that the appropriate supplementation can occur to prevent and treat any deficiencies.